If we can have Dr. Duchin come up to the podium. And we'll start with the session on general recommendations on immunization.
Thank you, Dr. Tempte, and good afternoon, or good morning, still in the morning. I'm happy to be able to introduce this section on general recommendations, and as you know, these are ongoing updates of a very large document that has multiple pieces. Let's see. So the general recommendations are published in the MMWR every 3 to 5 years, and they represent a broad range of immunization issues that are relevant to all vaccines as opposed to the vaccine-specific publications, for instance, the JE recommendations that we just heard. And the general recommendations are intended to address topics that cannot be attributed to a single vaccine, but that are germane to the practice of immunization in general. The general recommendations are directed to providers that give a large variety of vaccines and who come from a variety of different backgrounds and training, physicians, nurse practitioners, nurses, pharmacists, medical assistants, et cetera. And it's meant to provide resources through text, tables, and figures that can be used as a handy and easy to interpret reference. This is the current issue that was published in 2011, and the revisions have been ongoing, and as you may remember from past meetings, there are a number of topics that are being revised, including timing and spacing of immunobiologics and contraindications and precautions, which we presented to you previously. Today we'll be discussing adverse reactions, both preventing and managing them and reporting. And then there are other topics that will be dealt with in the future, including vaccine administration, storage and handling, altered immunocompetence, special situations, and so on. And you'll get briefings on those as we progress through them. Today's topics that Dr. Kroger will go over in more detail include preventing and managing adverse reactions and reporting adverse events after vaccination. And they're going to be combined in the new document into one section. So even within that topic, there are a variety of sub-issues, including benefit and risk communication, preventing adverse reactions, managing acute reactions, issues around persons who've had allergic reactions following previous immunizations, influenza vaccination of persons with egg allergy, vaccination with other vaccines in persons with a history of egg allergy, other potential allergens, latex allergy, reporting adverse events, and the National Vaccine Injury Compensation Program. So the issues that are highlighted here in red will be the ones that you'll hear about in the next session from Dr. Kroger. And you'll also, in the future, be briefed on vaccine administration, storage and handling, vaccination records, and vaccination programs. And we're anticipating the subsequent meetings in October, February, and June that are upcoming will also contain these briefings, and then you will be asked to vote on the entire document in 1 year from today. I'd like to thank my colleagues who have done a wonderful job in paying a lot of attention to detail across a whole host of different issues. My colleagues on the ACIP, Doug Campos-Alcalt, Mark Sawyer, and our CDC DFO, who does an outstanding job in coordinating and managing this large ongoing project, Andrew Kroger. So Andrew, I'm going to turn it over to you now. Thanks very much.
Thank you very much. So today's discussion will be for discussion only. There's no vote proposed. And we are going to focus on an update to one section to the document entitled Preventing and Managing Adverse Reactions. Quick definition, remember an adverse reaction is a clinical outcome that is recognized and known to be caused by a vaccine. I am going to try to cover in the next 35 minutes the major revisions, but so that you can visualize all the revisions, the ACIP members have two draft documents, or they should have two draft documents, one that has track changes and one that is clean. So hopefully you have those documents. I'll be referring to page and line references that will correspond to the clean copy that you have, the one without any strike through, when I talk about these major changes to this section. So here is a kind of a table that shows you the difference between the 2011 version of the General Recs and the 2016 version of the General Recs with respect to preventing and managing adverse reactions. Both had benefit and risk communication. The preventing and managing adverse reactions from 2011 focused on syncope only. The version for 2016 will keep the syncope content, but will then transfer the entire discussion on allergy from another part of the document. So this is not really new policy. We're talking about new things that we've done. We're just kind of moving content from one section to another. That the section that we're transferring allergy from is special situations. We talked about special situations in February, and I mentioned at that time that we were going to move the discussion of allergy to this new section. So you can see in the right-hand column then, the preventing adverse reactions, managing adverse reactions in the second and third bullet will include syncope and allergy. And then, of course, we are going to focus on specific topics as well, persons who have had an allergic reaction following a previous immunization, influenza vaccination of persons with a history of egg allergy, as well as vaccination with other vaccines in persons with a history of egg allergy, other potential allergens, and latex allergy as well. The work group made minimal changes to the sections on benefit and risk communication, reporting adverse events after vaccination, and the National Vaccine Injury Compensation Program. So I'm really going to focus on the sections in red. So again, we're going to focus on allergy right now. When it comes to the preventing adverse reactions, we didn't make changes to the syncope discussion at all. So when talking about allergy, we didn't really go in an entirely new direction. We rather made explicit in the new document some of the guidance that the general recommendations has always, and CDC has always kind of taken for granted. So when you talk about allergy, previous versions of the general recs have always presumed that providers do have the capability to take a history to diagnose allergy, determine if that allergy was anaphylactic in nature, kind of determine the level of the allergy, and determine which components are responsible. The current document makes all of these steps really more explicit. That language is on page 4, line 14, as well as page 5, line 4. But we are very careful with our language to not explicitly say that allergy referral will always occur, because we know that this is not feasible for every provider. So basically, we're just making some changes to the language with respect to preventing allergic reactions. In the section on managing acute vaccine reactions, there is language that we added that reads, vaccine providers should be familiar with identifying immediate type allergic reactions, including anaphylaxis, and be competent in treating these events at the time of vaccine administration. Providers should also have a plan in place to contact emergency services, as circumstances often require help from outside the office. So when it comes to managing acute vaccine reactions, we did want to, again, presume that providers are going to know what they're doing when someone reports allergy, but we also wanted to give an out for providers to perhaps refer to an allergist or seek help out from outside the office. And part of that was also involved a discussion of being able to contact emergency services when these reactions occur. So there are immunization providers who might be quick to refer to an allergist. They might never need to manage such reactions, but we did put in the document a description of symptoms. Page 5, line 10 and 11 contains specific symptoms and signs: local or generalized urticaria or angioedema, respiratory compromise due to wheezing or swelling of the throat, hypotension, and shock. And this comes after consultation with allergists that were mentioned in the acknowledgement slide of Jeff's presentation. We had them look through this document and make some changes. They were very, very helpful, especially when it comes to our needing to reiterate that for the management of allergy, for respiratory or cardiovascular symptoms or other signs or symptoms of anaphylaxis, immediate intramuscular epinephrine is the management of choice. The allergists really revealed that there have been cases where providers have withheld epinephrine. They felt somehow that a patient's underlying condition, whether it's a cardiovascular condition, somehow contraindicated the administration of epinephrine with understandable complications that have occurred from anaphylaxis. So we basically wanted to strengthen that language and just mention that intramuscular epinephrine is the management of choice. However, we will include as well separate tables for adults and children, both for adults and children, with additional diagnostic criteria and additional treatment options beyond epinephrine. Then there are specific discussions about and this kind of goes back to the issue of screening. So we do return to this discussion in the document. For persons who have had an allergic reaction following a previous dose of vaccine. And really, the essence of this section is a carryover from the 2011 version of the document, by which we refer to Robert Wood's article in Pediatrics, 2008, for what to do in this circumstance if the patient does report allergy following a prior dose of vaccine. This is not a component to a vaccine. This is an actual prior dose of vaccine in the history with a specific algorithm to be applied, identifying whether symptoms indeed are anaphylaxis, ascertaining the risk of disease if vaccine is withheld, as well as a number of interventions, applying skin tests like the skin prick test and the intradermal vaccine dose. And then finally, even if these tests determine that the condition may in fact be an intrinsic hypersensitivity or an anaphylactic reaction, to vaccinate under a controlled protocol, and of course based on the results of the skin test. And I wanted to show you just a picture of this algorithm, which is from the Wood article, for the management of suspected allergic reactions to vaccines. So you can see, just by looking down the algorithm, there are steps where you have to confirm the diagnosis of immediate hypersensitivity. Serologic testing for immunity is a part of this algorithm. That kind of gets to the risk of disease issue, whether you have to balance risk of withholding a vaccine in the context of anaphylaxis as well, followed by such diagnostic tests, skin testing. And I'll mention this was not discussed in great detail in the work group, but there has been kind of an ongoing programmatic concern about skin testing when applied generally to the issue of allergy. Whether vaccine should be used as a diagnostic tool in this manner, because when you combine skin prick tests and you combine intradermal testing, the amount of vaccine that's used in this process, informal discussion with the allergists really suggest that you are basically using one whole dose of vaccine to carry out all of these processes, the diagnosis and the controlled vaccination/immunization, in case you do decide you want to protect the patient. So again, it's not really extra vaccine we're talking about. This was of a concern. All of these doses, which are indeed are subdivided, right? You're giving smaller than the recommended dose amount, is an acceptable practice. It's all being given on the same clinic day, so we don't have to worry about repeating doses that might be deemed invalid in this circumstance. So the take-home is that this algorithm, which was in the 2011 document, is going to stay. So leaving aside now patients that report allergy following a previous dose of vaccine, there is a discussion of patients that report an allergic reaction following various components, and I'll begin with the discussion of egg consumption. So first I'll make the point that when it comes to this guidance, it is not generalizable. The guidance is actually pretty specific to each vaccine. One example I'll mention right off, since I talked about the Wood algorithm in the past slide, is skin prick testing is not recommended for influenza vaccination following history of allergy to eggs. So there's one kind of difference where this type of recommendation, but it is recommended for yellow fever vaccine following a history of allergy to egg consumption. So this guidance is really not general. It's specific to each vaccine. And so rest assured that this discussion in the general recommendations document will follow very closely to the discussion in the influenza vaccine statement. There's a large section in your document that runs from page 7, line 6 through page 9, line 5, in which we talk about this. And there was discussion in the work group, should we focus so much on this? Shouldn't we just leave this to the influenza vaccine statement? And I think we're gonna keep this in here for several reasons. First of all, I think when you talk about general vaccination, influenza vaccine is now one of the most broadly administered vaccines when it comes to various age groups. We recommend it for all persons 6 months of age and older. While pediatric influenza recommendations were first really issued in 2004, and by 2010 we did have recommendations for everyone 6 months of age and older, but over time there's been more and more attention to allergy following allergy in the screening process for influenza vaccine, because there's going to be a lot of attention to first-time recognition of allergy on the part of providers generally, and this first-time recognition will likely occur among infants and children with respect to influenza vaccine. So I think it makes sense to really make sure that this discussion is in the general recommendations document when it is published, but we'll make sure that since the influenza recommendations come out every year, and this is really not going to be published, sometime between 2014, 2016. We will make sure it is up to date. But there is a discussion as well of egg allergy and other vaccines besides influenza vaccine, particularly yellow fever vaccine, varicella vaccine, and MMR vaccine. And this discussion is on page 9, line 6 through page 10, line 10. I'll make an apology that I probably need to do some typesetting with the document. I don't really separate this discussion out as much as I should from the discussion of influenza vaccine and egg allergy. But there is a discussion with these other vaccines, and there are differences. I've already mentioned yellow fever, where the history of egg allergy is relevant. We do recommend procedures like prick test or scratch test recommended prior to administration via desensitization, whereas for some other vaccines, such as varicella and MMR vaccine, we make the point that history of egg allergy is really not relevant prior to using these vaccines. There is a discussion of other allergens and history of allergy to other allergens, thimerosal, neomycin, and latex. Again, I'll make sure that these topics are clearly distinguished in the document. There's some typesetting in your version that you have that I need to work out. Latex has its own special section. That's kind of the history of this document. We used to have a huge paragraph on latex. The information really is still valid, so we're going to leave that in. And really the message common to all three of these allergens, and it's a very important point, which is covered in the document, is that contact allergy, as opposed to immediate hypersensitivity allergy, a type 4, what's called a type 4 reaction, is not considered a contraindication to administration of vaccines containing these components. And this is a very important point because contact allergy is much more common than immediate hypersensitivity for these three components generally and will come up more often during the screening process. I will make the point, however, that if allergy is deemed severe, there is language, not in this section of the document, but in a section that I have covered previously with the ACIP, contraindications and precautions. Remember that the general contraindication is severe allergic reaction, e.g., for example, anaphylaxis after a previous dose or to a vaccine component is considered a contraindication. It's listed as a general contraindication for all vaccines. So it's very important to understand this because it does give some flexibility, discretion to providers, which is a good thing. It uses anaphylaxis as an example and not the only type of severe allergic reaction that may give providers pause. Providers very well may construe other forms of allergy as contraindications, and so it really gives that discretion to a provider, which I think is a good thing in the context of making general recommendations. Of course, most contact allergy is usually not considered severe for the most part. So I want to remind the committee that language is in the contraindications and precautions section. And also there is a circumstance, vaccine-specific circumstance with less flexibility, specifically allergies that include respiratory components probably in most cases will, per the vaccine-specific, or the influenza vaccine specific ACIP statement, would probably contraindicate live attenuated influenza vaccine because wheeze, or history of wheeze within the past year really is considered a contraindication. We state a specific preference for the inactivated product in that circumstance. But that information is accounted for in the influenza specific statement, and any changes to the general recs will parallel the language in the influenza specific statement. And then lastly, just to make sure I cover all of the topics under this section, for reporting adverse events after vaccination and National Vaccine Injury Compensation Program, again, any small changes will be highlighted in your draft. There really are no major changes from the 2011 General Recommendations Statement. And of course, the language in this section is based on policies of programs that cross-cut other HHS agencies. And so, of course, our language is going to match the official programmatic language for these programs, and we'll make sure that it gets that appropriate vetting. With that, I'd like to leave. I guess I have 15 minutes now for any questions or discussion on this topic.
Thank you, Dr. Kroger. Any questions here? Yeah, Dr. Rubin.
I have a general sense that an egg allergy in general is a much bigger deal for yellow fever vaccine than for influenza vaccine. If that's correct, and if that's what your allergist consultants say, then I think I would probably make sure the language is a little bit more clear on that.
That the language is more clear.
That, if yellow fever vaccine and there's a history of egg allergy, basically you don't give it unless you really, really, really need it, where for influenza it's much more nuanced and there's a lot more experience and lots more publications and so forth. That's my sense, but if that's correct, I think I would make a more declarative statement like that.
Dr. Sawyer.
Andrew, you cited several examples where you have vaccine-specific recommendations in the general recommendations that are intended to match those in the vaccine-specific documents. But since the general recs are only published every 3 to 5 years, is there some sort of statement to readers of the general recommendations that they should also refer to vaccine-specific statements for perhaps the latest information? Or how do you handle the fact that it's hard to make them always match exactly?
We definitely will make sure that there are citations and references. Maybe the question is a good one. Do we put actual language in text that says refer to the recommendations versus just a citation that links to a specific reference in the endnotes? And we've had this discussion a lot in the general recommendations work group, and we mix and match. Sometimes we do that, sometimes we don't. But I'll take that as a comment that we should probably make specific references to specific text, specific ACIP statements in the text of the document.
In a quick follow-up to that, also, a lot of people access this electronically on the web. And I'm wondering if you equip that with hot links over, if there is a statement on a specific vaccine that a click would take you over to a more detailed in that statement for that vaccine.
I know that hot links like that exist from the table of contents of ACIP statements to other sections of the same document. I'm not sure, but I can find out if it goes to other. Actually, it does. Errata, yeah. So yes, there are those types of links that take you from one document to another. So I can look into if that's possible to put that in where we can do that.
Dr. Keitel.
Would it be possible if you're revising sections one at a time and you come out with substantially updated recommendations to publish interim recommendations, much as we need to do for influenza?
Yeah, we used to have provisional recommendations that would allow us to put certain components of these major documents. We can put earlier sections of it up online more quickly, and that was, we don't do that anymore. I don't think we're doing provisional recommendations anymore. One of the challenges with provisional recommendations, from my perspective, was that it did go through an exhaustive clearance process. It almost slowed down work on the primary document to get that through. I don't know if that would be a similar challenge to trying to break this up, unless we actually made a radical decision to break this document up into completely separate documents, perhaps.
Well, it was my understanding that there's a difference between interim and provisional recommendations. And if there really is a big change in your allergy section, then could there just be interim recommendations for from the general recs doc regarding allergy?
Yeah, I think if there's a section of the general recommendations where there would be a need for an update, interim recommendations would have to come to ACIP and be approved by ACIP and adopted by the director. That could be done, and then they could be linked into the original document, so you could say there are updated recommendations that would link into the MMWR where they would be published. So that is possible to do, Andrew. I think if you could work that with your work group, that could be done.
Dr. Hahn?
Yes, I was wondering, now that an egg-free influenza vaccines are available, whether there was consideration given to adding specific language about that under the influenza egg allergic section, either for the milder or the more severe allergic patients. It's not mentioned at all, and a 30-minute observation period is a burden for a provider that versus the 15-minute standard. So it might be worth at least putting that as an option, that if available, that could be used.
I think that's doable. I think we'd want to make sure it mirrors exactly and we'll keep up with what's in the influenza vaccine specific ACIP statement when we do that, because it's challenging to define egg-free, and that's, I think, still being worked out. So, but we will follow what the influenza vaccine specific recommendation says.
So the recommendations will be discussed tomorrow, and technically there is only one egg-free vaccine, which is the recombinant hemagglutinin vaccine. And the issue there is that most of the egg allergy problems occur in children, and this vaccine is not recommended for children.
Dr. Freierhofer.
Sandra Freiho for AMA and ACP. Again, talking about the egg allergy, that's sort of like a big topic now, since we're now giving some vaccines that can possibly contain egg to egg allergic patients or subsets of them. And I'm starting on page 7, if there's any way we can make it sort of pop a little bit more, so when a busy practicing clinician looks through these, it's sort of easier to find this information. I think on page 7, when you say all but one of the influenza vaccines may have come into contact with egg protein, don't keep us in the dark. just tell us which one it is in a parenthesis. And I think that conversation that you mentioned about the confusion about these two, the flu block and the Flucelvax, it's really repetitive for so many of you in this room because you do this all the time. But this is a big year for new vaccines in the influenza arena. And then going on to the next couple of, like on page 9, can you put a little subset that says yellow fever, then one that says mumps and measles, and the varicella, because that way, when you start this section, you see flu and you think it's all about flu, and then when you really read it, you realize it's not all about flu. So make it easy for us. Thank you.
I'll fix the typesetting definitely and separate those sections out.
Dr. Herman.
So I like the box, with the medical management of anaphylaxis, but in both the boxes for infants and children and adults, there's nothing that says when the provider should call EMS. At what point? How many shots of epinephrine do you give before you call? And, I think that would be very, very helpful, because I wouldn't want them trying and, I would rather see a prompt referral to EMS if a patient's in trouble.
Right, so the reference is to a table in the draft, which I've sent an email to get permission to use. It's a very detailed, and I haven't heard back yet, so it's still draft. Consider it draft. Whether we'll even get that detailed, we may have to make some adaptations if we can even use all that information in terms of diagnosis and treatment. But we also, part of the discussion in the work group was definitely make sure that there is a sentence, and it is in the document that allows providers and gives them an out that they can contact emergency services if they don't feel like they can do all of those steps. That was a big point of discussion.
But I think they need to know when that is. And when I'm looking at the box that you need permission for, and it's not in there either. It does not say, at this point, you've given, 2 doses, stop and call EMS, or don't stop, but call EMS. It just goes on to talk about epinephrine infusion, which I don't think you'd ever do in an office, and,
Okay.
I'm going to call on Dr. Lair and Dr. Brady from Family Medicine Peds. My impression is when I call my nurse for the crash cart with the epinephrine, I'm also having them call the EMS. But I'd like to just get your comment about the sensibilities of practitioners in usual care.
Yes. Yeah. I think that as time has gone on, the interest in getting EMS involved is getting quicker and quicker. I think that's just the way it is. And I think, with the exception of the allergists, most of the pediatricians would call EMS.
And so it seems that a comment could be made in the algorithm just saying that in most clinical circumstances, the call for epinephrine is also an appropriate time to call for advanced services. Other comments or questions? Okay, you're making this far too easy. It is 11:41, and if there are no further comments, we will stand adjourned until 1 p.m.